Thank you very much. If I can get the lights down straight ahead of me, that would be fantastic. So I'm giving you a talk on an overview of pulmonary hypertension, really as a prelude for the next two presentations on CT and MRI in that setting. I'm going to be talking a little bit about background of pulmonary hypertension, briefly about the imaging techniques we can use to try and define the cause of pulmonary hypertension and detect pulmonary hypertension. Talk in a bit more detail about the classification of the disease and how that impacts on therapeutic options. So pulmonary hypertension is defined by raised pulmonary arterial pressures, mean pulmonary arterial pressures of greater than 25 millimeters of mercury at rest. Now, unfortunately, patients present with non-specific clinical symptoms, often resulting in a significant delay to diagnosis being made. Increased pulmonary vascular resistance ultimately results in overload of the right ventricle, which will ultimately fail, leading to initially progressive dyspnea, syncope at exercise, syncope at rest, and ultimately death. It's a progressive disease. Broadly, causes include, on the left-hand side of that slide, diseases of the small vessels. On the right-hand side, causes secondary to a range of other causes. Left heart disease being a major cause, lung disease another very big cause, chronic thromboembolic disease increasingly recognized as a cause. We'll run through the classification in a bit more detail. But just to say that pulmonary hypertension in and of itself carries a poor prognosis, whatever the cause of that pulmonary hypertension. So small vessel diseases have a bad prognosis, median 2.5-year survival without treatment. If you have pulmonary hypertension secondary to heart disease, left heart disease, or lung disease, the outcome of that disease is worse than if you didn't have pulmonary hypertension. We have a range of imaging modalities available to us to evaluate patients with suspected pulmonary hypertension. I'm going to run through those briefly, but leaving lots of space for the next two presenters. It's important to recognize that the lungs, the pulmonary vasculature, and the right side of the heart are all in series. So it's important that we recognize they act as a functional unit. We need to treat them as a functional unit, and we need to try and diagnose them as a functional unit. And that's where I think the real strengths of CT and MR come into the evaluation. Chest X-ray will be the first-line imaging test for the evaluation of patients with non-specific cardiorespiratory symptoms. It's relatively insensitive in detecting pulmonary hypertension, but may identify those features you see on that slide. Enlargement of the right heart chambers, dilatation of the proximal pulmonary arteries. As such, it's fairly non-specific. Many causes of pulmonary hypertension could cause similar findings. When we see abnormalities such as that, amputation of the more distal pulmonary vessels with distension of the more proximal ones, it's pretty suggestive of chronic thromboembolic disease of a cause. An uncommon finding to feel confident about that, but that's pretty specific X-ray. Another chest X-ray showing lung parenchymal disease, and obviously plain film's quite sensitive, quite insensitive in detecting mild disease. But when you've got pulmonary hypertension secondary to lung disease, it's usually pretty severe. Echocardiography, an early imaging test, gives us detail of cardiac anatomy as well as cardiac function, allows us to assess both right-sided cardiac chambers, left-sided cardiac chambers for cardiac causes of pulmonary hypertension, as well as looking for intracardiac shunts. It gives us functional and morphologic information. It also gives us functional information about systolic right ventricular pressure and estimation of pulmonary arterial pressure. VQ scintigraphy has been widely performed in this group of patients. Its main role is to differentiate chronic thromboembolic disease, as seen on that slide, from non-chronic thromboembolic disease. This patient has small vessel disease. You can see the perfusion's not totally homogeneous. It's slightly moth-eaten in its configuration, but doesn't have those wedge-shaped defects you see in the chronic thromboembolic patient. So VQ scintigraphy still plays a role in that differentiation, but I think you'll hear from the next two speakers that both CT and MR are reasonably good at making that differentiation. Pulmonary angiography, even in these pulmonary hypertensive patients, is a relatively safe procedure, gives us great anatomical detail of the pulmonary vasculature. But again, that's all it does. It gives us projectional images of the pulmonary vasculature. CT and MR, I think, give additional complementary information on cardiac morphology, function, and the lungs. Angiography will typically be performed at the same time as a right heart catheter. We don't tend to do this. It's the physicians, certainly in our setting, or cardiologists that do it. But a cardiac catheter involves passage of a pulmonary arterial flotation catheter through the right heart chambers into the pulmonary vasculature. Enables direct assessment of pressures along its route, so allows direct assessment of pulmonary arterial pressures. It's the gold standard for a diagnosis of pulmonary hypertension. It also allows assessment of oxygen saturations along its route, and therefore we can identify step-ups in oxygen saturations to indicate an intracardiac shunt. CT, again, you'll hear much more about it. It allows comprehensive assessment of the lungs, the vasculature, and the heart. MRI, again, you will hear more about. Non-invasive technique gives really good non-invasive assessment of cardiac anatomy, cardiac function. Also gives very good anatomical detail of the pulmonary vasculature and functional information on the pulmonary vasculature, looking at perfusion imaging. Now, we've got lots of techniques available to us. How do we try and integrate them into a sensible pattern? This is what we do locally. It will depend on where you work, what expertise you have, what facilities you have, and local preference. But basically, chest X-ray and echocardiography, early imaging techniques to raise the diagnosis, establish a diagnosis. CT, I think, certainly in our setting, is a very valuable triage tool as to whether you identify large vessel disease, features consistent with small vessel disease, or cardiac disease. An MRI we use as a problem-solving technique directed at the cardiac patients, also directed at our pre-surgical chronic thromboembolics. Moving on to the classification of pulmonary hypertension. This has changed certainly since I was a medical student, but it's not changed that much over the recent past. The great and the good meet in very nice places to reclassify pulmonary hypertension. There have been a number of reclassifications, but things haven't changed significantly, I think, since 1998. I'll run through the classifications, but broadly, these are now clinical classifications, trying to group together causes of pulmonary hypertension which have similar pathophysiological mechanisms and therefore similar treatments. Broadly, what I'm showing now is the previous classification. I'll highlight the interval changes. We've got small vessel diseases. These are the group 1 diseases. Pulmonary arterial hypertension is diseases of the small arterioles. Pulmonary veno-occlusive disease and pulmonary capillary hemangiomatosis, diseases more distally in the vasculature towards the venous and capillary end of the circulation. Initially, chronic hemolytic anemias were in this group. They have since come out of this group, moved into group 5. Similarly, persistent pulmonary hypertension of the newborn used to be considered one of the causes of a small vessel arteriolar process. That's come out of that classification, but remained in the small vessel disease group of causes of pulmonary hypertension. So one double primed. Let's run through some of those. So pulmonary arterial hypertension may be idiopathic. This is a disease of small arterioles. Idiopathic or secondary to other causes. Other causes of pulmonary hypertension include common diseases. Pulmonary hypertension secondary to left heart disease. That may be due to left ventricular dysfunction, either systolic or diastolic, may be due to valvular heart disease. These are common disorders. Another reclassification was placement of congenital causes of raised left atrial pressure into this group, less relevant to adult images. Another common group, pulmonary hypertension secondary to chronic lung disease or chronic hypoxia. Chronic thromboembolic disease, we'll mention more of later, under-recognized disease. And then there's a really catch-all group 5, which includes a variety of rather disparate disorders. So let's start by looking at the small vessel diseases, starting with pulmonary arterial hypertension, diseases of the small arterioles, less than a centimetre in diameter. These all have similar pathophysiological mechanisms. They have endothelial dysfunction and similar pathological appearance with proliferative changes involving those small arterioles, involving intima, media, and adventitia with proliferation and thrombosis of those vessels. That's the so-called plexiform lesion you see there, typical of pulmonary arterial hypertension. Now, it's considered that the cause of pulmonary arterial hypertension is multifactorial. Some people will be predisposed to it, some people won't. All of them can still go on to ultimately develop pulmonary arterial hypertension. They will see insults along their lives, be they continuous insults from connective tissue disease, be they sporadic insults from toxins, drugs, viruses, etc. The more predisposed you are, the more likely you are to develop pulmonary arterial hypertension symptomatically. So causes of those arteriolar diseases may be idiopathic, maybe IPH, idiopathic pulmonary arterial hypertension, or heritable pulmonary arterial hypertension. Both of them are uncommon. They both have poor outcomes if left untreated, median survival under 3 years, but outcomes are improved with targeted treatments, which we'll mention. We've increased our understanding of these diseases, partly helped by the hereditable group, in that BMPR2 receptor mutations are common in the setting of heritable disease. 80% of people will have them. Even apparently sporadic cases, a significant proportion, will have that genetic mutation. Moving on to other causes of identical pathological changes. So pulmonary arterial hypertension associated with connective tissue disease is pretty common in the setting of systemic sclerosis. Around 10% of people will develop it. It has bad outcomes, twice as bad as that of idiopathic pulmonary arterial hypertension. But again, there's a reasonable response to targeted therapy. So it's important that we diagnose the disease, diagnose the presence of pulmonary hypertension, and intervene early with targeted therapy. And that's why routine echocardiography is commonly performed in that group of patients. Other insults to the vascular endothelium, viral infections can be associated with the development of arteriolar disease, pulmonary arterial hypertension, HIV, where it's considered more associated with the viral infection itself rather than the level of immunocompromise. Interestingly, in that group of patients, outcome tends to be very good if you give them targeted therapy to the vascular endothelium. Portopulmonary hypertension, so pulmonary hypertension associated with portal hypertension, occurs in around 5% of people with portal hypertension. Outcomes tend to be really pretty poor, I think in large part because of the comorbidities. They've got portal hypertension, they've often got cardiac disease as well. A range of drugs have been associated with the development of pulmonary hypertension. The level of confidence in that association varies from definite associations on the left-hand side of that slide, likely associations in the middle, and possible ones on the right. An increasing number of drugs are being found to be associated with the development of pulmonary hypertension. Moving on to congenital heart disease, increased flow or increased pressure in the pulmonary vasculature puts shear stress on the vascular endothelium, predisposes to the development of pulmonary arterial hypertension, abnormality of the arterioles. Congenital heart disease is quite common. Survival is getting better as surgical intervention occurs sooner, and a significant proportion of these patients go on to develop pulmonary hypertension either in late childhood or adulthood. The likelihood and stage at which that pulmonary hypertension develops depends upon the nature and size of the shunt. in that high pressure shunts tend to result in early development of more severe pulmonary hypertension, so VSDs, for example, whereas low pressure, low volume shunts will result in pulmonary hypertension at a later stage and of a lower level. So ASDs tend to present with pulmonary hypertension later. And it's important to recognize that even in adulthood, in a patient with pulmonary hypertension, we commonly recognize previously undiagnosed cardiac abnormalities. That's a sinus venosus ASD. That's a patent ductus arteriosus. We need to, as imagers, look very carefully for these shunts, even in an adult population, even when they've had an echo. Echo is not that good at both of those abnormalities. I'm sure you'll hear more of that. Outcomes remain poor in patients with arteriolar disease. Outcomes are worse in patients with non-idiopathic diseases. We've increased our understanding of the vascular dysfunction, the endothelial dysfunction, the molecular biology underpinning pulmonary arterial hypertension, which has led to a greater understanding of the pathways involved and development of specific therapies targeted at those pathways. The drugs you see there can be used either individually or together in the management of patients with pulmonary arterial hypertension. Moving on now, a bit further down the pulmonary circulation, staying on small vessel diseases, but we're moving on to veno-occlusive disease and pulmonary capillary hemangiomatosis, so-called 1' diseases. Veno-occlusive disease affects predominantly the small venules, resulting in fibrosis of those vessels, occlusion of them, thrombosis, and capillary engorgement. Pulmonary capillary hemangiomatosis results in proliferation of the capillaries. Both of them cause pulmonary hypertension. Both of them are very uncommon. Both are generally considered to be idiopathic, but other secondary causes have been identified as outlined there. They tend to present fairly non-specifically, often with a slightly more accelerated decline than patients with idiopathic pulmonary arterial hypertension, and worsened gas transfer in comparison to those with idiopathic pulmonary arterial hypertension. Outcomes are slightly worse than arteriolar diseases. And importantly, if you treat this group of patients with treatments targeted at the arterioles, cause arteriolar dilatation, they can develop acute pulmonary edema. So it's important that the clinician is aware that this is a potential possibility, these 1' disease may be present. And again, I think that's where we potentially come in. We play a role in saying that in small arteriolar diseases, typically the lungs will look normal or subtly abnormal, subtle centrilobular ground glass nodules. Whereas in these 1' diseases, the parenchymal changes are usually more obvious, more diffuse, dense ground glass opacity seen in that case, some interlobular septal thickening. That's veno-occlusive disease. This patient has pulmonary capillary hemangiomatosis, again, more obvious parenchymal abnormalities, dense centrilobular ground glass nodules, more diffuse ground glass opacity, very different appearances. And I think when we see those abnormalities, we need to be alerting our clinicians to the potential of these more venous/capillary end of the circulation diseases, each of which also commonly has small volume lymphadenopathy associated with them. Moving on now from small vessel diseases to group 2 diseases, secondary to chronic left heart disease. Broadly, these can be divided into cardiac disease due to systolic dysfunction of the left ventricle, obviously ischemic cardiomyopathy being the most common, valvular heart disease, and diastolic dysfunction to the left ventricle. No matter what, they cause increased left atrial pressure. That requires an increased driving force through the pulmonary arteries to maintain cardiac output, i.e. requires pulmonary hypertension. Early in the disease, there will not be vascular remodeling, so you'll see raised pulmonary arterial pressures, raised pulmonary capillary wedge pressure, but normal pulmonary vascular resistance. But then small vessel remodeling will happen in this group of patients, very similar to the small vessel diseases we described, pulmonary arterial hypertension, identical pathological changes, resulting in further increase to your pulmonary arterial pressure. Group 3 is pulmonary hypertension secondary to chronic lung disease or hypoxia, another very common cause of pulmonary hypertension. Obliteration of the vascular beds, hypoxic vasoconstriction, resulting in increased pulmonary vascular resistance. It's a common condition. The majority of patients with severe lung fibrosis, severe COPD, will have an element of pulmonary hypertension. Pulmonary hypertension is more common when you've got a combination of the two in combined pulmonary fibrosis and emphysema. It is important to recognize that the severity of pulmonary hypertension in patients with chronic lung disease is usually not that severe. It's difficult to push your mean pulmonary arterial pressures beyond 35 millimeters of mercury with pure lung disease. If you see arterial pressures higher than that, it suggests there's something else going on, such as associated small vessel disease. We'll mention it. Chronic thromboembolic disease has been under-recognized as a reservoir of patients out there with this disease. It complicates up to about 4% of people with acute pulmonary emboli. Those emboli may not fully resorb. They may become endothelialized, recanalize to form the webs you see in the bottom panel there. I'll show you what that looks like to the surgeon looking down the vessel. The top panel there shows a web just almost completely occluding the right lower lobe pulmonary artery. You can just see small fenestrations, punctate fenestrations. The important thing about chronic thromboembolic disease is that potentially the surgeon, if you've got the right distribution of disease, can remove that obstructive burden. And they remove casts of endothelium and organized thrombus looking a bit like that, and it has a dramatic effect. And that effect is dramatic on imaging grounds, total reperfusion of the middle and right lower lobes. It's dramatic on functional grounds. So right ventricle going from looking fairly tired and saggy to a really normal-looking right ventricle post-procedure. Marked improvement functionally. These are breathlessness classes going from pretty badly impaired to pretty normal in the majority of cases. And also marked improvement in the pulmonary arterial pressures. You see pulmonary arterial pressures on average halved. Pulmonary vascular resistance dropped by 2/3. It's a procedure associated with a significant mortality, 3% mortality in our hospital, but the mortality of the underlying disease is considerably higher than that. Again, important to recognize that when you've got proximal obstructive disease and pulmonary hypertension, your more distal vasculature in the perfused areas will witness raised pulmonary arterial pressures, and that can result in remodeling of the small vessels in your apparently normal lungs. So some patients will have disproportionately raised pulmonary arterial pressures in the setting of chronic thromboembolic disease due to an associated small vessel vasculopathy. That group don't tend to do well with surgery. Instead, they do better with medical treatments, and medical treatments are increasingly being recognized as an option for patients with more distal chronic thromboembolic disease. I'm only going to talk about group 5 very briefly, really to highlight that there are systemic disorders which can result in disproportionately raised pulmonary arterial pressures in comparison to the severity of lung disease we see on imaging. Examples would include Langerhans cell histiocytosis, where we know you get Langerhans cell infiltration of the lung parenchyma. You can also get infiltration of the vasculature and therefore a disproportionate pulmonary arterial pressures in comparison to the severity of lung disease. The same applies to sarcoidosis. Granulomatous involvement of the small vessels can result in disproportionate pulmonary hypertension for the severity of lung disease. And the same would apply for systemic sclerosis, where you may have a mixed vasculopathy and interstitial fibrosis. Just to show those images, again, group 5, other causes of vascular obstruction. Chronic thromboembolic disease and acute pulmonary emboli, we know obstruct pulmonary arteries, but other diseases can also involve the large vessels. Sorry, let me go back. The left-hand panel shows a patient with a pulmonary arterial sarcoma, which is distending the pulmonary artery lumen instead of retracting it, which chronic thromboembolic disease does, has a convex medial margin to it. PET can help increase our confidence that we're looking at a sarcoma. Similarly, pulmonary arterial vasculitis causes diffuse thickening of the pulmonary arteries, usually intramediastinal elements of the pulmonary arteries. And again, that doesn't look typical of chronic thromboembolic disease because of this ill-defined margin with the adjacent fat. And again, sometimes PET can help increase our confidence of vasculitis. This patient actually had activity in their aorta, not in their pulmonary artery. In terms of treatments, we've mentioned targeted treatments to pulmonary arteriolar disease, pulmonary arterial hypertension. Treatment for patients with pulmonary hypertension secondary to left heart disease will be directed towards the left ventricle with medical treatment, maybe surgical treatment with revascularization or valve replacement. Pulmonary hypertension secondary to chronic lung disease, the mainstay of treatment will be long-term oxygen therapy. And finally, we've mentioned chronic thromboembolic disease and the potential for surgery and in some cases medical treatment. When should we treat? The answer is ideally not late in the disease process where the impact of treatment may be very limited. We want to be treating early in the disease process, try and reverse the vascular remodeling process. To briefly summarize, pulmonary hypertension is an under-recognized disease. It presents non-specifically and therefore is often diagnosed very late with consequent high mortality and morbidity. There are lots of different causes of pulmonary hypertension. Those causes have very, very different treatments. We as radiologists, I think, play a pivotal role in this disease, both helping suggest the disease. We may be the first to suggest the disease. We may help establish a specific cause for that disease, for example, chronic thromboembolic disease, intracardiac shunts, left heart disease, easily diagnosed by us. We may help assess the extent of disease and guide treatment. Is it a surgically amenable chronic thromboembolic disease? Are there features of 1' disease, veno-occlusive disease, to suggest that medical therapy should be introduced very carefully? Different imaging modalities have different strengths, different weaknesses. We need to understand them. Often we may find that different imaging techniques may be combined in a complementary manner. Finally, I think it's important that we work closely with our clinicians to help diagnose, refine diagnosis in this group of patients. Thank you very much.